This recorded lecture will be going over Chapter 39, Promoting Musculoskeletal Function in the Fundamentals textbook. Many conditions such as strokes, fractures, surgery, and neuromuscular disorders will require bed rest for a patient to heal and recover. These periods of bed rest can result in immobilization. This is the prevention or restriction of normal body movement in a patient. Problems caused by immobilization include pressure injuries, pneumonia, loss of bone mass, and permanent loss of function in the immobilized part. Dangers of immobilization include pressure injuries, loss of bone mass, pneumonia, and permanent loss of function. Good nursing care is critical in preventing complications for immobilized patients. A decrease in muscle strength and coordination, generalized weakness, stiff joints, constipation, and abdominal distension will begin within a few days of immobility. One of the major concerns when a patient's movement is restricted is the development of respiratory complications. Physical activity will cause people to breathe more deeply, expanding their lungs and encouraging clearing of secretions. On page 807 in table 39.1, you can see the effects and problems of immobility, and the next few slides will be focusing on that table. Without adequate physical activity, secretions can collect in the lower airways, leading to congestion and ultimately respiratory illness, particularly hypostatic pneumonia. This is pneumonia caused by stasis of secretions due to inactivity or hospital-acquired pneumonia. Range of motion exercises, frequent turning, and the use of deep breathing exercises can help prevent pneumonia and increase general oxygenation. Circulation is affected by immobilization. Normal movement assists in venous return by compression of the muscles against the venous walls when muscles are in motion. Healthy, firm muscles will provide general support for those venous walls. It's important to monitor the general circulatory status of your patient and monitor their blood flow to the affected body area on a regular basis. Increase fluids to at least 3,000 ml per day, encouraging adequate nutritional intake and increasing dietary fiber to help prevent GI system complications. Perform active or passive range of motion exercises to maintain joint mobility and muscle integrity. This is a standard of practice for bed rest care. Encourage active movement of the unaffected extremity throughout the day to assist in maintaining muscle tone. When a patient is on extended periods of bed rest, isometric exercises can be beneficial. Turn the patient every 2 hours. Keep the skin clean and dry, providing smooth, clean linens. Use pressure relief devices to prevent any pressure injuries. Immobilized patients can experience a variety of emotional responses. Provide support, use therapeutic techniques of communication that focus on listening and allow the patient to verbalize their concerns. When signs of fear and stress are observed, take time to listen and refer these patients to social services as appropriate. Another frequent problem for the alert, immobile patient is boredom. Chat with your patients about things that interest them while providing care. Do something creative like crocheting or crafts. Cards, texts, phone calls, emails, and personal visits will increase the patient's sense of value to others and their feelings of self-worth. Positive feelings are known to play an important role in a healing process. For the immobile patient being cared for at home, it may be helpful to move the bed into the living room or family room to reduce any social isolation. Remember that the non-alert or comatose patient also needs emotional support. Always assume patients can hear and understand you, even when they cannot respond or respond inappropriately. Talk to the patient about what is going on in the world. A splint is a device that protects an injured body part by immobilizing or limiting its movement. A splint can be used as a first aid measure before a cast or traction is applied to an injured part, or it can be used instead of a cast. Traction is the application of a pulling force, and it is used to maintain parts of the body in extension and alignment. It's used to realign bone ends following fracture and to relieve pain and nerve impairment caused by compression or muscle spasm. There are three types of traction: manual, skin, and skeletal. The amount of traction is determined by the pull exerted by weights at the end of traction ropes. Initially, the muscles tend to be tight and can go into spasm. A heavier weight will be required to overcome the muscular pull and allow the body to resume a normal alignment. The head of the bed should be no higher than 20 degrees to keep the patient from sliding down in bed and keep weights hanging free. A slight Trendelenburg position may be ordered to keep the patient from slipping down in the bed. The weights should swing freely without touching the bed or the floor. The patient in traction should have an over-the-bed frame with a trapeze bar attached to the bed. The trapeze bar can be grasped by the patient to assist in their repositioning. With manual traction, the hands are used to aid in the realignment of fractured bones. This is typically performed by a physician prior to placing an affected extremity into a splint or cast. Skin traction will offer short-term pain relief from muscle spasms due to muscles and tendons pulling the extremity into a shortened position. In skin traction, a Velcro boot, buck traction, belt halter, or sling is applied snugly to the skin, and the traction is attached to an appliance. Damage from skin traction includes blisters, rashes from irritation by adhesives, and skin tears and tissue injuries from the shearing effects of the lateral pull across the skin surface. The amount of weight that can be applied is limited to a maximum of 10 to 15 pounds. Skin traction is generally not used with older patients due to their fragile skin. Skeletal traction will require the surgical placement of pins, tongs, screws, or wires that are anchored to or through the bone and then therefore pierce the skin. As much as 30 pounds of tractive force can be used for this type of traction. An orthopedic technician can set up the traction. The LPN is responsible for maintaining the correct weight and alignment of the traction and for maintaining a balance between the traction pull and the counteraction force. Skin care around the openings for the pins, tongs, or wires needs to be performed according to the medical order. Sterile technique needs to be used when performing pin care. On page 810, see box 39.2, Guidelines for Pin Care. Use sterile swabs and cleanse closest to the pin in a circular motion. Then secure the ends of wires with cork. Clear fluid drainage is expected initially. Circulation checks need to be performed every hour for the first 24 hours and every 4 hours thereafter. Patients can be placed directly into a cast following a fracture or variety of orthopedic procedures, or a cast can be applied after a period in traction. Most casts are made of fiberglass, polyester resin, or thermoplastic material. Heat can be felt as the casting material is applied, especially with the plaster of Paris. Casts made of synthetic material will dry rather quickly, in about 7 to 20 minutes, and can be hardened enough to be durable within 30 minutes. It is critical to protect the cast from uneven pressure during the drying period because the shape or position can inadvertently change. On page 811, see the clinical cues. When handling the cast during the drying period, use the palm and the flat parts of the fingers rather than your fingertips. Dents in the cast can lead to circulatory impairment and pressure injuries, and changes in alignment can alter the position of the healing parts or impede circulation. Swelling of the tissues is common during the first days after a cast is applied, and if this is left uncontrolled, it can impair circulation and cause a pressure injury. A casted extremity needs to be elevated on pillows. Hip spica cast can be particularly challenging for both the patient and the caregiver. Hip spica cast will encase a portion of the trunk and part or all of both legs. Do not use the spreader bar as a handle for lifting and turning the patient. This can be dislodged, ruining the cast and then causing pain and possible injury to the patient. Instead, grasp the cast over the leg to assist in turning. Frequent turning is necessary, including prone positioning, to ensure complete and uniform drying. It's also very important to protect the cast from soiling. Maintaining the skin integrity of an incontinent patient in the spica cast is a great challenge for the orthopedic nurse. Most patients can go home after cast placement. Be sure to show the patient and family how to check the cast edges for any rough spots or crumbling, how to use pillows to elevate the extremity to prevent swelling, and how to pad the rough edges using tape or moleskin. A damaged cast will always need to be replaced. A major concern for patients with casts is bathing. Plaster casts need to be kept dry or they can disintegrate. Even fiberglass casts are a problem if they become thoroughly wet. When a child is sent home with a cast, it's important to stress the dangers of placing any small items inside the cast. These can cause pressure necrosis and infection. Casts will be removed using an oscillating saw. On page 812, see the clinical cues. Prior to cast removal, inform the patient that the skin underneath will be dry and dirty in appearance, with an unpleasant odor. Wash with warm soapy water, rinsing and applying cream or lotion to remove any dead skin cells and help that skin return to normal. Apply vitamin E or any recommended ointment over the healed incisions to improve their appearance. An external fixator is a metal device such as a pin, screw, or tong that is inserted into or through one or more bones to stabilize fragments of a fracture as it heals. This type of immobilization will allow the patient to be more active during their healing process while still maintaining immobilization of the fractured area. The pins, screws, or tongs in the frame need to be checked for stability every 4 hours. On occasion, illness or injury can result in long-term or permanent immobility. Kinetic and air fluidized beds can be used to help decrease the incidence of complications. Air fluidized beds will contain tiny silicone beads within the bed under a flexible air permeable filter sheet. Warmed air will pass through the small particles, setting them into motion so they act as a fluid that suspends the patient free from contact with any stationary or hard surface. Air fluidized therapy is effective in the prevention of pressure injury and will help reduce generalized body pain common among bedridden patients. Air fluidized therapy is not recommended for patients with unstable spines or ambulatory patients. To maximize the beneficial effects of therapy, the unit should be in the fluidized mode at all times. Low air loss support beds are achieved by distributing air through multiple cushions connected in a series. The cushions are calibrated to provide maximum pressure relief for the individual patient. Shear and friction are reduced or eliminated because the cushions give with the patient during any movement or rest. This bed is contraindicated for a patient with an unstable spine. Lateral rotation therapy beds, such as the roto-rest bed, are believed to decrease the incidence of lung collapse and hospital-acquired pneumonia. They can facilitate normal urine flow and reduce the risk for deep vein thrombosis as well as pulmonary embolism by encouraging venous flow. Skin breakdown is reduced by the pressure reduction foam in a gel pack surface. The degree and rate of movement are programmed to meet the individual patient's requirements. There are a variety of accessories that aid in the reduction of skin trauma from pressure for patients in standard hospital beds. These would include foam and gel pads, sheepskin pads, and heel and elbow protectors. Pulsating air pads and water mattresses will lie on top of the regular mattress and provide additional pressure relief. After orthopedic surgery to replace a joint, continuous passive motion or CPM is often ordered to restore joint function. A purpose of the machine is to exercise extremity of the joint, thus preventing contracture, muscle atrophy, venous stasis, and thrombus formation. Physical therapy is often ordered for the patient who is immobilized for an extended period of time. Full ROM exercises should be performed either actively or passively several times a day. To prevent joint injury while performing passive range of motion exercises, be sure to support the limb to be exercised above and below the joint. When performing a head-to-toe assessment of the immobilized patient, be alert to any indicators of circulatory impairment, such as reddened areas, pale or blue skin, coldness, or diminished or absent pulses. Look for any signs of respiratory impairment, such as shallow breathing, rapid or depressed respiratory rate, cough, abnormal lung sounds, use of accessory muscles, retractions or grunting, generalized paleness, duskiness, or cyanosis. Perform a neurovascular assessment for any patient with a cast or traction device. When the patient is in traction, assess the pulleys and ropes for proper function and free movement. For the patient in a cast, observe and document any foul or musty odor from the cast. Check all assistive devices and equipment for structural problems prior to use. On page 815, see box 39.3, the neurovascular assessment. Remember your 5 P's: pain, pallor. Check the capillary refill of the affected extremity. Normal capillary refill is less than or equal to 3 seconds, or within 5 seconds or less in the older adult. 5 seconds or less in the older adult. Paralysis and paresthesia. Inquire about any feelings of numbness or tingling. These are paresthesias. Check the sensation with a paperclip and compare them bilaterally. The sensation should be the same. And pulselessness, the 5 P's. Planning care for the immobile patient will require careful consideration of time needed to assist the patient with various aspects of their ADLs, the time needed for treatments, and the time to be spent providing diversional activity and socialization. Appropriate interventions include regular turning and positioning, use of pressure relief devices, coughing and deep breathing exercises, range of motion exercises, assisted ambulation, and visitation, or activities addressing the psychosocial needs of the immobile patient. When caring for a patient in a fresh plaster cast, elevate the cast on pillows if possible. Elevating the extremity will reduce the likelihood of swelling, and turn the patient hourly so that the cast will rest on a different area of its surface and then dry evenly. On page 821, see box 39.4, Guidelines for applying an elastic or roller bandage. Be sure to overlap the turns of the bandage equally. Elasticized bandages are applied to immobilize a joint or to apply pressure to reduce swelling. They also may be used to provide support to a wound and hold dressings in place. Circular turns are used to anchor the bandage and to terminate the wrap. Circular turns are used to terminate the wrap. Spiral turns are used to bandage parts of the body that are uniform in circumference, such as the upper arm or upper leg. A spiral reverse turn is used to bandage body parts that are not uniform in circumference, such as the lower leg or forearm. A figure of 8 turns are used to bandage and stabilize an elbow, knee, or ankle, or to immobilize and hold a fractured clavicle in position. A recurrent turn is used to cover the distal parts of the body, such as the ends of a finger, the skull, or a stump left by amputation. The thumb spica is a variation of the figure 8 bandage used to support the thumb in a neutral position following a sprain or other injury. This technique can also be used to help bandage the hip or shoulder. A sling can be used to support and immobilize an injured wrist, elbow, or shoulder. The sling will hold the extremity in an elevated position to avoid any edema of the hand and minimize pain, comfort, and fatigue. Lifts can be used to move immobile patients from the bed to a stretcher, a chair, or a wheelchair and back again. Never leave a patient requiring the use of a lift unattended while in the lift, in the tub, or in a whirlpool bath. When using a lift, explain to the patient exactly what's being performed. Before placing a patient on the sling, be sure that their skin is clean and dry. Protect the sling as needed with a sheet or bath blanket. Some rehabilitation units will have a walking sling that can be suspended from the ceiling and support the unstable person when ambulating. Be sure to place all assistive devices within easy reach of the patient whenever they are not in use. A walker is frequently the first mechanical aid used when training an individual to walk, following a loss of function or a surgical procedure, such as a hip or knee replacement. This is particularly helpful for patients who are weak or tend to lose their balance because it will offer a broad base of support. Walkers are adjustable in height. The height is correct if the person's elbow is bent at a 15 to 30-degree angle while standing upright and grasping the hand grips. Depending on the person and the need for assistance with ambulation, the use of crutches can follow the use of a walker or be the first aid to ambulation. Axillary crutches are commonly used for short-term needs. They're adjustable to a variety of heights and are relatively easy to use, but they do present one real danger. Resting the body's weight on the axillary bar will put pressure on vital nerves and can occlude blood vessels in the axilla. This can cause temporary or permanent damage, including paralysis. For this reason, it is critical that crutches be adjusted to the proper height and the patient be instructed to avoid resting their body weight on the axillary bar. Crutches need to adjust both overall length from the axillary bar to the hand grip. Measure the patient when standing or supine. On page 827, see the blue patient education box, Special Maneuvers on Crutches. When walking upstairs, you need to stand at the foot of the stairs with the weight of the good leg and weight on your good leg and your crutch. Then you put your weight on the crutch handles, lift up your good leg first onto the first step of the stairs. Put your weight on your good leg and lift the other leg up and the crutches to that step. Repeat that for each stair step. The most commonly used canes are the standard 1-point and the quad 4-point canes. An advantage of the quad cane is that it can stand up by itself. Wheelchairs are used for patients who are not able to ambulate either independently or with aids, such as crutches or a walker. Many paraplegics, quadriplegics, amputees, and individuals with severe hemiparesis or respiratory problems can be dependent on wheelchairs for movement from place to place. Patients who are wheelchair dependent over an extended period of time will need chairs that are made specifically to their body measurements. When a patient brings in a wheelchair to the hospital, see that it is clearly labeled with the owner's name and never borrow it for someone else. When moving someone into and out of a wheelchair, always be sure that the brakes are set. To prevent any accidents, keep patients in wheelchairs well away from stairwells, elevators, and doorways if left to sit stationary, and always lock the brakes when the chair is not in motion. Braces and splints are used to strengthen and support areas of the body affected by weakness or paralysis, such as the legs or back. They also may be used after surgery or trauma to immobilize a part while it heals. Braces and splints are generally made of plastic or metal pieces with padding and straps for attachment. A prosthesis is an artificial substitute for a body part and can be used to replace a body part that is missing either from birth or following amputation. This is specially fashioned to fit the patient and assist with the loss of function. It will take considerable time for a patient to adjust to the use of a prosthesis. All braces, splints, and prostheses have the potential to irritate and injure the tissues and therefore need to be monitored closely. The skin should be evaluated carefully during the initial assessment and then reassessed regularly throughout the hospital stay or at home. Be sure to label all devices with the patient's name and do not allow them out of the room unless they are in place on the patient. As patients recover from their immobilization or serious illness that would restrict their typical activity, an exercise prescription may be written to improve their muscle tone, joint flexibility, and cardiovascular fitness. Parameters for this exercise would be determined by a target heart rate during activity. This will be based on age and condition. In a healthy person, the target heart rate for aerobic activity is a minimum of 60% the age-predicted maximum heart rate. To calculate this, you subtract the current age from 220 and then multiply by the percentage. The ideal training target is 80% of the age-predicted maximum heart rate, according to the American Heart Association. When evaluating our patients, ask yourself the following questions. Does the skin remain healthy, or are there signs of breakdown? Evaluate breath sounds and note any developing cough or signs of dyspnea. Observe your patient's emotional status, including their attitude toward therapy and visitors. Is the patient alert and active in social interactions, or are they withdrawn, hostile, and depressed? If nursing interactions are not achieving the expected outcomes, the care plan then needs to be revised. Each member of the healthcare team needs to maintain a written record of treatments provided as well as its effects. Documentation should include any changes in skin integrity, respiratory status, or signs of any peripheral circulatory changes.